Hello and welcome to the Clinical Liver Disease video series. Clinical Liver Disease is an official digital learning publication of the AASLD. My name is Vinay Sundaram and I'm a transplant hepatologist at Cedars-Sinai Medical Center, and I'm also a guest editor for Clinical Liver Diseases. And I'm here with Dr. Alan Hutchison, who is a gastroenterology fellow at the University of Chicago, who has authored the article we are going to discuss. Dr. Hutchison, how are you doing today?
I'm doing very well, thank you. How are you?
I'm doing well, thank you. So your article was very interesting, and I did want to get into some questions. But first, if you wouldn't mind, can you give us just a brief summary of what you wrote about and why you wanted to write on this topic?
Yeah. So I wrote about dichotomization or polycautization, which is the division of continuous variables into two or several groups. And it's a very common thing we do in medicine. You know, we determine, is a patient sick or not sick? Are they stable? Or are they somebody we need to watch overnight? But it turns out that when we use this in kind of more advanced techniques of designing clinical trials or developing risk scores for assessing levels of disease, it turns out they have some undesirable statistical properties that can seep in and, you know, lead to bad results.
Excellent. So what are some of the costs and benefits of using polycautization versus dichotomization?
Yeah, well, so, you know, the benefits are clearly that it's easy to do, and we do it automatically in our heads. And, you know, back when all we had were paper charts and computers the size of rooms, this was pretty useful, you know. So a good example is the child's Pugh's Turcotte score, where, say, you know, the INR, if it's below 1.7, you get 1 point. If it's 1.7 to 2.2, you get 2 points. If it's above 2.2, you get 3 points. And you can do that on the fly. You can do that at the bedside. And that's pretty easy. But, you know, now we have electronic medical records and we have supercomputers in our pockets. So we can calculate kind of much more advanced things than doing this kind of back of the envelope calculations. You know, the cost is that when we think about the INR in that way, you know, the patient with an INR of 1.6 is not different from the patient with an INR of 1.7, but suddenly we're separating them out into two different groups somewhat arbitrarily. You know, we also see this in histology. So the NAFLD score is a score that where the pathologist looks and says, there's a little, a medium, or a lot of steatosis, and same for ballooning and lobular inflammation. But now with artificial intelligence, we can say exactly what percentage of the slide has ballooning or has fibrosis. And so we don't need to use these kind of gross heuristics anymore and lose all the data that's incorporated there. This loss of data is not just a theoretical loss. You know, doing this weakens the predictivity of risk scores and increases the cost and number of patients needed to identify differences in outcomes in randomized controlled trials.
So that's an interesting point, and I do agree with you that that, you know, when you dichotomize a set of variables, that you are probably losing some of the predictive accuracy because not everything is black and white. There are shades of gray. But here's my question for you. Again, scientifically, I agree with you, but how do you implement polycautization of variables in the clinical setting? You know, in particular, when we are taking care of patients, certainly when I explain things to patients, it's easier for them to conceptualize a yes or no or a black or white kind of, you know, particularly because the majority of patients are not of a medical background. So it does make it simplified. So I'm wondering if you had any thoughts as to, you know, directions we can move forward with in terms of implementing some of the work that you've written about in the clinical setting.
Yeah, you know, so the main thing I wanted to emphasize in my piece was that, you know, we should avoid categorization as far along in the thought process as possible. So, you know, when you're dealing with something continuous like the INR or a patient's bilirubin or even a patient's MELD score, you know, until the last moment of decision making, you should keep things as continuous as possible and not make any gross generalizations. But you're right, at the end of the day, we have to decide, you know, are we going to give this patient semaglutide or are we going to offer them a transplant? But what's important to note is that it's not just yes or no, it's, are we going to offer them a transplant today? Or do they need to come back in 5 years or 1 year or 6 months? And if we make these sharp delineations and say, you know, your MELD is 15, we're not offering you a transplant today, go have a good life. That's not how it works, right? It's like, I'll see you back in a year and we'll see what things are. If their MELD is 20, or if MELD's 30, God forbid, but they're not a good psychosocial candidate, then you say, okay, come back in a month and we'll see where things are. Come back in 2 months. And so we actually use that continuous data. And so into the last moment of decision making, we should keep it continuous, as opposed to saying their MELD is between 20 and 30, or the MELD is less than 20, or the MELD is greater than 30. We should be avoiding those generalizations till really the last clinical moment.
Okay, very good. You also discuss about polycatomization of outputs. Can you explain the difference between the polycatomization of inputs, such as the INRs you mentioned, and the outputs?
Yeah, so the inputs is kind of the obvious case where it's very clear that there's a continuous variable and we're throwing away that data. The outputs is a little more subtle and insidious because it's very common in the literature to look at studies and say, okay, here's our low MELD versus high MELD people, and now let's look at their characteristics or their response to a particular medication or a particular therapy. But it turns out that looking at the outcome in terms of, did their MELD fall? Did their MELD rise by 2 points, by 5 points? Instead of saying how much did it fall or rise, we end up losing a lot of data. So, in the toy example, where you take a normally distributed output, which MELD isn't, but let's say it were, and you identify that exact cut point that distinguishes the sick and not sick people. If you treat it as discrete, as 2 groups instead of as continuous, you need 1.5 times as many patients or as many samples in order to find the same amount of difference as if you just treated it as continuous, right? So if you would rather have 150 patients in your study than 100 patients, you should go ahead and dichotomize. But I suspect that everybody wants to do things a little less expensive with a little less risk to patients in those studies.
Very good. Are there alternatives to polycatomization?
Yeah, so the most basic example, right, is comparing the child's Turcotte-Pugh score to the MELD score, right? So the child's Turcotte-Pugh polycatomizes both at the inputs and the outputs, right? So namely, your INR, your Billy, your albumin all get converted into a point, +1, +2, +3. And then at the end, you have this output, which is continuous, or 5 to 15, but then you end up polycatomizing again and giving it an A, B, or C.
Correct.
On the MELD scores is the counterexample, right? So in that case, the inputs are all plugged into an equation as they are. And then the number you get out, it's rounded to the nearest integer, but it's continuous. And then there's no polycatomization there, right? You have that score. And so, that's kind of the ideal situation where you've gone from something where you polycatomize inputs and outputs to something where you're polycatomizing neither. And then, like I said, at the very last step is when you can make a decision based on that result, and then that decision is going to fall into a category. But before that step, that's what we should be doing. And so it's the child's Turcotte-Pugh score served us very well for several decades, and now MELD and MELD sodium and maybe MELD 3.0 are replacing it in practice. But there are plenty of other risk scores, both in hepatology and in gastroenterology in general, that use this kind of polycatomization. And they're likely to be outcompeted by new risk scores that don't polycatomize.
Very good. So we'll finish just by asking, what do you think are the benefits specifically to the field of hepatology for moving away from polycatomization?
Yeah. So one thing that we're working on getting better at in hepatology is that, unlike say cardiology, where you have tens of thousands of patients and you have your adverse outcomes that happen pretty quickly, decompensation from cirrhosis, the development of HCC in NAFLD patients, these are things that take decades, and they're things that take thousands of patients to have a couple of occurrences. And so we can't run the same scale of trials as cardiologists can. And so we're dealing with much smaller sample sizes and much more important but rare events. And so we need to be more efficient in how we design trials. You can, if you have 100,000 patients, sure, you can polycatomized left and right, and you're still going to find a signal. But when you're dealing with the limitations that we have in hepatology, we have to be as efficient as possible when we're designing studies and thinking about how to best use the precious patient data we have.
Thank you very much. That was a very interesting interview on what I think is a topic which we're going to hear a lot about in the future as we start to advance in research, particularly with artificial intelligence and machine learning and natural language processing to gather patient-specific data. So I do look forward to hearing more about this. Do you intend on continuing work in this area?
I do. I'm looking at some retrospective patient data to actually see, how wrong we're getting it with the child's pew, or how much better we could be improving when we don't polycautomize. There's plenty of examples in the literature of studies that have either not accrued enough patients or have missed their endpoints, which use this polycautomization at several steps. And so, I think it'd be worthwhile to go back and look at those and say, did we just not analyze this data, in the best way? And is there a signal here?
Great. Thank you very much. So we will conclude the interview here. I just wanted to say on behalf of all of us from the CLD team, I hope that all the viewers found this interview both educational and informative. For more information about this topic or additional topics, please visit us at www.cldlearning.com. Thank you to everybody for watching. And again, Dr. Hutchison, thank you for participating in this very interesting interview.
Thank you for having me.